Okay, I think we're going to go ahead and get started. This platform is a little bit different for me. We're trying a webinar instead of just a regular Teams meeting. So bear with me, but as always on our Friday morning, I like to keep it a little bit informal. Um, but welcome to the January TPM webinar. And we were putting our slides together. We usually intend on doing this one kind of in December. The way the fourth Friday fell, it was right after Christmas this last year. So we decided to do the year review in January as opposed to doing it at the December TPM webinar. So you'll see a little bit of multiple things here, a little bit of 2023 data, and then a few numbers kind of by the numbers as far as the Bureau goes. That represent 2024. So I will try to keep that clear as far as which year we're looking at since we are now in January. Make sure my volume's up here. Okay. Looks like we have a good turnout though. So 42 people, that's good. And I have no idea why people are waiting in the lobby when some people aren't, but that's on my end. So looks like everybody's having a good Friday, a good week of IT issues. Yeah, including this morning as well. So thanks for being here today. I really appreciate you taking the time out. So let me try to get all of these. I don't know if you guys can hear that on your end, the people that I'm trying to admit. Okay. All right. So kind of some updates from the state is usually how we start this year in review. And it was a good year, definitely. A lot of changes happening, especially with the patient registry. And Dr. Foss is going to kind of go over a few of those things here at the end of the or halfway through the presentation when he kind of takes over. And I just want to give a huge shout out to Nick, as I call him, Dr. Foss. He has done amazing work with Image Trend this year, has really kind of kept them honest, I guess, really watching data elements, updates, issues. He's very quick to put in tickets. Anytime anyone has had an issue, Nick does an amazing job of following up and really holding Image Trend accountable. And many of you have been around for a few years and know that it has not always been like that, where we've had really excellent accountability to Image Trends. So I just want to take a minute here to recognize Dr. Foss for all the work that he's been doing with Image Trend. It's been amazing. We very much appreciate you. Okay, just some kind of recap, very high level overview here. I think this gets confusing, especially if you're new to trauma program managing across the state. It's kind of hard to understand how we are set up. But this is kind of the hierarchy here where we follow and how we fall into things. And we've got just a little bit of background, so please mute yourself. Thank you. So we used to be the Department of Public Health, and it would have been July 2023 where they first started going to the Iowa Department of Health and Human Services. So Iowa HHS is kind of how we reference ourselves now. We're no longer IDPH. We do fall in then the next level down is the Division of Public Health. And then under that division is our Bureau of Emergency Medical and Trauma Services. So that's where we fall into. And if you ever need our current website, here's the website listed there. And here in a minute, I can drop it into the chat. And I apologize if there's people trying to get onto the meeting, but I'm not that great about multitasking, emailing, and talking at the same time. So I apologize if I seem a little distracted.
Sarah, I can take care of that for you. Don't worry about it.
Yeah,
I'm getting everybody in.
Okay, yeah, I've got a couple emails popping in wanting the link too, so we'll have to get to them when we can get to them. So, um, thanks, Nick. In case you're not familiar with who we are, and why aren't my pictures coming up? There we go. Love that secret animation that's on there. This is the entire trauma team for the Bureau of Emergency Medical and Trauma Services. So Margaret McComas, as you know, started with the Bureau in my role, and then Jill followed her, and I followed Jill. And then Dr. Foss got hired in 2023 as our epidemiologist, and he works officially point 0.5 for us, but I feel like he's maybe a 2.0 FTE in our bureau, but we appreciate him very much. And so we are a small but mighty trauma program. So just if you're not familiar with our faces, that's who we are. This is just kind of, again, a high-level overview of our Bureau of Emergency Medical or Trauma Services, or BUMPS, as you'll hear us refer to once in a while. That's one thing with state, hospital, and military. We all love our acronyms very much. So there's a lot that happens in our bureau. I certainly was not aware of that when I first started, but we do all sorts of different programs. And this is just kind of a quick recap of the different programs that are offered, that are active and very much involved with in our bureau. The law enforcement AED program, that is issuing AEDs. And you can see there in the numbers, and we have quite a bit of work that goes into the AED program, and Dr. Foss helps generate some of the data that is coming out of the AED program. Our First Responders Comprehensive Addiction Recovery Program, or FRCARP, again with the acronyms. And this is what is another program that Reagan oversees here in our bureau. And that's providing training in Narcan to EMS agencies. And in 2024, we had 363 EMS agencies trained up. That is not a total number. That was just a number for 2023. EMS, obviously, the big side of our bureau, over, I think, 790 some EMS agencies in the state of Iowa. So that's a lot of work for our EMS colleagues on the other side of the bureau. Just shy of 400 inspections just for the year 2024. Katie also led 5 training center on-site inspections. There are multiple medical director and service director workshops, 250 plus participants through those workshops throughout the year. So very busy on the EMS side as well. Another part of our bureau is the emergency medical services for children, and that's led by Vicki Peterson. There's her contact information there. So far to date, this slide is just a little bit hard to see. I didn't quite realize that, but there's 635 pediatric emergency care coordinators, or PECs. If you have had a verification recently with me, we have probably mentioned the IPEC or the PECs. So the IPEC is the Iowa Pediatric Emergency Assessment and Care, and you can be a recognized hospital. Again, this does not mean you have to be a certain size of a hospital. This recognizes all hospitals of all sizes to ensure that you have pediatric initial stabilization equipment, that you have processes in place, a treatment area, and policies in place that recognize this pediatric patient is beyond our resources and we need to transfer the patients out. So Vicki does a verification survey very much like our trauma verification. And you can reach out to Vicki if you're interested in being a recognized pediatric emergency assessment and care center. And there is a great application, and it can help you be better, especially if you feel, as with many places do, feel like maybe that we're just a little bit uneasy when that pediatric patient comes in. So this is a great program, and it helps you be better. I did add this 4th bullet point, and we're going to talk about this here in a few slides, but through these webinars, you've heard us say, or if you were on TSAC, we've been talking about waiting from the American College of Surgeons to hear the level 4 standards come out. So in 2014, the Orange Book, that's when we had our verification criteria for levels 1 through 4. And when the new standards came out in 2022, or the Gray Book, um, the college had standards for level 1s, 2s, and 3s. Over the course of that time, many advocates here from the state reached out to the college, including Dr. Plias and Dr. Sidwell, very active in national COT, said, hey, we have to have some rule standards. They need to be recognized. Our hospitals, if you're a hospital in the state of Iowa, you're a trauma center, and there are 100 level 4s in the state of Iowa. We need to have some updated standards. So the college took that very much to heart, and they have been developing these level 4 standards to reflect updates. And one of them, again, we'll kind of talk a little bit more about this, is that they'll want to see that a pediatric readiness assessment has been done at our level 4s. So granted, this will be many years from now when we have these level 4 criteria approved and finalized from the college, then released, educated on, and then we have the legislative process that we need to get these level 4 standards adopted into Iowa Administrative Code. And then we will start verifying level 4 centers off of there. So there will be many years, I hope not too many, but there will be many years before these level 4 standards come out. But this is kind of a heads up that pediatric readiness is a focus for the college, and that, as it should be at the level 4s, when you're in a rural area with limited resources, we want to give tools to the sites to help them understand where they sit for pediatric readiness. All right. I'm going to pause here for just a minute because I have about 6 emails of people trying to get in. So stand by.
I can fill some airspace for the moment. As Sarah was talking about the drafted level 4 standards from the American College of Surgeons, just to let you all know, they sent the draft version to the state trauma program managers, so the me and the rest of the 50 states, just for review and to get feedback. So right now they're in the feedback gathering phase. So we fill out a survey to see if we think that these standards are appropriate for, our states. And then after they review all of that, I believe that there's going to be another level of feedback requested from the American College of Surgeons, and they might extend that to more of the trauma centers and things. So that's where we're at with it. But yeah, like Sarah said, there's a spoiler alert that they are looking into having all the hospitals be assessed through pediatric readiness. So that's my little plug. It looks like Sarah might be ready to go again, so I'll give it back to her.
Yeah, thanks, Jill. So again, kind of our high level overview of where we're at for trauma centers. And you heard me say this already once, but if you're a hospital, you're a verified trauma center. That's what it means to be an inclusive trauma system in the state of Iowa, which we are. Currently, as of today, we have 3 level 1 ACS verified trauma centers in the state of Iowa, 2 adult and 1 pediatric, 4 level 2 ACS verified centers, 2 adults and 2 pediatric, 1 level 3 ACS verified center. And if you are a level 3, you can be an ACS level 3 or a state level 3, which we have 12 state level 3s and 100 level 4 state verified trauma centers. And get Jill to drop that link in the chat as well. This is our trauma care facilities in Iowa website. This goes right to our map, and there's a PDF before you start searching for your TPM if you're looking for TPMs across all of the trauma centers, they are listed there with their emails. And there's a PDF at the top of this. And that is where we're keeping our most up-to-date information. I send this into comms quite frequently to reflect any changes in the TPMs across the state. And if there were changes in the verified trauma centers, I also get that as quick as possible to comms. They're usually pretty good about getting it fixed on the website. So this is updated frequently. I just wanted to bring that to everyone's attention. Again, if you're looking to not reinvent the wheel and know some close colleagues that share or if you don't know your colleagues, but share the same regions, share the same county, reach out to your fellow TPMs. They may have a policy, and that's one thing that keeps us connected is that we do all have similar issues and similar processes. So reach out and make some of those connections as well. This is kind of a busy slide, and I'm not going to read this verbatim. This is just kind of a overview of where our trauma program funding is. And again, when I started here, or even when I started as a previous TPM, I had no idea that the majority of the trauma program for the state of Iowa is federally funded through a CDC block grant. I just assumed, okay, yep, the state's paying for the trauma program. But Jill has done phenomenal work making sure that our our annual grant application is turned in every year, and that we can receive those monies to keep the people on the previous slide, keep their faces employed. So some of that money obviously goes to our trauma education. 2 years ago that Jill supplied for the AAAM AIS course, CEUs for monthly webinars, our TTDC books, trauma verification survey team contracts. So our verification team that comes with me to your sites to keep them verified, we do pay them as contracted employees, the physicians, surgeons, and nurses. Some expenditures to go to the NASEMSO conference and the Advance in Trauma Region 7 in Kansas City conference. That's where some of those monies go as well. So I think that's just something to be aware of about our state trauma program. So trauma program by the numbers for 2024, I just kind of went back and reviewed what have I been doing, I guess, in 2024. We have 39 verifications that we got done in 2024, 8 paper, 13 virtual, and 18 on-site verifications. We are heavily weighted on on-site, which I love to be on-site, seeing people in person, seeing their resources in person. I love looking at hospitals. I love getting ideas from all the hospitals and taking them to other hospitals. And yes, all of that can be done virtually, but as I have completely proven this week, virtually is not my strong point. And then 8 paper verifications. I would encourage any paper verification people that say, oh yeah, it's just a lot easier to do paper. I would encourage you to do an on-site. Jill can attest to this as well. We hear over and over again how much more valuable the on-site and virtual verifications are versus the paper verifications. I will say with the 39 verifications and 18 of them, that does keep me quite busy. I really appreciate your patience, and I appreciate the survey team members being flexible with dates from the site standpoint. Please communicate if there are dates that just cannot work. I will do my best to work around that. If you're really after an on-site verification, we will do our best, but I may not be right in that expiration month just because it is a lot of calendars to schedule around between the hospitals and the survey team members and myself. So on-site is fantastic, just patience and grace with those on-site verifications. Last year, we issued 93 criteria deficiencies, 2 citation and warnings, and 2 sites on probation in 2024. Technical assistant visits, this is 59 total, 19 trauma program related, 20 registered related, and 20 code report writing. And that is Dr. Foss. Many times we will try to do a collaboration in case there are questions between your report writing and how do you actually apply that to the verification criteria. So Nick copies me in on those invitations, and we do try to do a collaborative approach when our schedules work. We had 9 TPM webinars last year for speaking engagements, and this is the number that I want to just take a minute here. In 2024, we were 27% turnover for our trauma program managers at statewide. And a lot of this obviously is beyond anyone's control and why that is. But I think this is an important fact just to realize that if you are planning on stepping out of the role, have some succession plan in place. It really is a lot of work. We recognize how much work it really is. There is, and this goes with anything, not even just the TPM role, but the passing the torch is really imperative when it comes to performance improvement, because performance improvement just doesn't end after your verification, it's continuous. And having that gap in your trauma program manager duties or your trauma coordination duties really hurts the site when it comes verification time. So encourage you to have succession, to get some training, and to also reach out to Nick and myself for technical assistance. We will certainly do what we can to guide you, but I'm sure it's frustrating on your ends if we are not answering emails quick enough or being able to supply enough information. We certainly do try. There is a welcome letter that I send out to new TPMs once I'm aware of that. So please, if you're leaving or know of a new person, just shoot me a quick email, and then that way I can make contact with that new TPM. And in the welcome letter, hang on to those, because there are all sorts of resources and websites that kind of explains what am I doing here, right? Some 2024 projects that happened as well for the trauma program. We did the 2024 Trauma and Preparedness Conference. Jill did an amazing job coordinating all of those efforts. That was a lot of work, and hopefully it was beneficial. Dr. Foss, Nick has been working on Trauma R and NESCOR packages, which I will be completely honest, I cannot even begin to explain in layman's terms. So we'll let Dr. Foss handle that when he is coming up. Again, we kind of talked briefly on this about updating the trauma registry and the data dictionary. The data dictionary, again, is pending because we are on that red tape review or the rule-making moratorium, and the data dictionary is referenced directly in Iowa Administrative Code. So we have to go through the steps to get the new data dictionary into Administrative Code, and all of that is on hold per Governor Reynolds right now. Dr. Foss took some posters to NASEMSO this year, and that was the first time, which he did an amazing job as well on that. The trauma registry report, and we'll be talking about that coming up. He revamped the CQUIC indicator reports that each facility gets. So if you see those emails come in from Dr. Foss, make sure you're taking a look at those. We're going to talk about those coming up as well. We were able to increase the trauma surveyor verification team rates, which had not happened in several years. So that was definitely beneficial as well, to keep those surveyors involved and having enough to get those on-site verifications happening. And then improvements in the image trend elements, which we have definitely seen some benefit come through with those. And I'm sure this group has heard this several times, so I'm not going to spend too much time on this. And I just briefly said, as you know, we are still on our rulemaking hold. That's why it feels like we have old resources for you, but we are limited until we can get some of our newer things into administrative rule. But it's coming. That was the last piece there. We are getting very close to the conclusion. So that's good news. And then this is really just what Jill said here about getting the feedback for these level 4 criteria. I think the takeaway here is that the current level 4 criteria, and I'm not even sure how much for the level 3 criteria out of the Orange Book, which we are on right now as state verification trauma centers. There were 72, I think, in the level 4 criteria, and that's going down to 30. So that is a significant change. But as you know, especially those that have been through the verification or looked at the verification checklist on our website, that it is very repetitive. And that was by design in 2014 when it came out of the Orange Book. However, now that it seems more streamlined, when Jill and I took a first look at these new level 4 standards, and that's another language term, they've gone from criteria out of the Orange Book to standards out of the Gray Book. So I do think it will be beneficial to level 4s to have those less standards, to be more streamlined and not feel like, okay, I already showed you this, but I feel like I'm repeating myself for showing you the different criteria in the other chapters. So good news coming from these level 4. They look pretty good. I need to go through them in a lot more detail as well. And again, the takeaway here is that we recognize tight resources at level 4s. We recognize how rural we are. We recognize the need for, again, resources, getting patients transferred, bed availability at the larger trauma centers. We recognize all those issues that are happening in our rural state. And I certainly keep that in mind when I'm reviewing new level 4 standards, as does Jill, as does Margot. So we hear issues and we feel like we have a handle on what the issues are at the level 4. So we appreciate that continuous feedback, and just know that we are working to make this better. So looking forward to 2025, number one there is complete the red tape review. So we need to get that moving. We have Dr. Foss redid the data dictionary, the state data dictionary, so we'd like to get that in. The legislative process to adopt the Gray Book, as noted, will take a little time, but the Gray Book and those new level 4 standards we would love to see implemented into administrative rule. There's still a new national guideline for field triage of the injured patient, a 2021 version that has not been approved through administrative rule yet. So very much looking forward to the conclusion of this red tape review. Few other things here, always looking for sustained funding for the trauma program, updating the Iowa plan for the trauma system. And I think I put, yeah, there it is. Hosting the American College of Surgeons Trauma System consultation visit in September of 2025. And if you have not heard Jill or I speak about this yet, you will soon. Jill, did the save the dates go out too? Yeah, or are we still waiting on comms for that?
Yeah, the save the dates have been sent out to some of the stakeholders that we would like to be present at the table.
Okay. This is a big deal. This is on the level of, well, it's the college, it's the American College of Surgeon Surveyors coming to not verify a trauma center, but they're coming to verify a trauma system, to verify the state trauma system. And I should not use the word verify, but that they're coming as a consultation, but they are coming to do the same thing as a verification. There are no standards or criteria deficiencies that the state would receive for things that we didn't have, but the consultation is the same caliber as a verification visit, as several surveyors, several physicians, several experts across the nation coming in taking a look at everything from your pre-hospital resources, how many ambulances are available in this region versus how many trauma centers are available versus how many times that trauma center is on diversion. They want a statewide diversion time, which means all of our 120 hospitals, how many times were they diverted, or how many minutes or hours were they on diversion, and a trauma patient had to go elsewhere, thus increasing time to a trauma care facility, thus potentially having poorer outcomes. So they're looking at every single detail of the trauma system as a whole. So Jill's doing a tremendous amount of work on that, and that will be coming in September 2025. So that's going to be our biggest goal for 2025. Trauma System Advisory Council. So you've heard me already reference TSAC. If you're not familiar with TSAC, this meeting happens 4 times a year. We thank you for your patience this week. The state has moved from Zoom licenses to Teams, and from Teams, there's apparently some audio issues when we get over 100 participants on the meeting. So we are working through all of those challenges right now between Zoom and Teams. And I honestly can't tell you if the next TSAC meeting is going to be on Zoom or Teams, but we will keep those communications out there and keep everyone informed of how we're having which platform on our TSAC meetings. But please take note of these dates. They're from 1 to 4 in the afternoon on the 3rd Tuesday of the month. Again, there's only 4 meetings. Please hold your calendars now so you can participate. And there are, this last one, what did we have? 119 people log on for the TSAC meeting. And people are like, well, what's the point of TSAC? Well, TSAC are our subject matter experts, which are you people. You people are working every day in the trauma system, in the hospital. You recognize what issues you have, what things are working. And this is a meeting for all of that, for all of the people to come together and talk about different issues, different things that we want to do as a state. There's information that comes from all of the programs that I just listed. We get an update from NSAC, which is the EMS side equivalent to TSAC. And these advisory councils, that's what helps the Bureau to make decisions on what's going to be best for the trauma system. So it's an imperative part of the trauma system is TSAC. And I would encourage everyone to spread the word. Everyone's invited, any trauma stakeholder, ER docs, trauma registrars, EMS personnel, very trauma focused, but this is a great meeting to really kind of come together, and it's informational too. Many resources are shared, and we keep updates from the college coming down. So this is a great meeting. Please hold your calendars and please participate. And then our monthly TPM webinar series. This is the 4th Friday of the month from 10 to 11. And again, I recommend putting your own calendar hold on until we can sort out all of our Zoom and Teams and recurring meetings and things like that. We are going to send out the link into the trauma bulletin. This is what the trauma bulletin looks like, and it will be coming from, you can see the address there from Iowa Department of Public Health at public.govdelivery.com. Please make sure this is not going into your spam and the garbage. This is where the link for this meeting will be located. The link will change based on whether we have applied for continuing education hours. So that's why we don't want to put a series onto everyone's calendars. As soon as you make a change, everyone's calendars change. So we're just really trying to streamline the process. I appreciate your patience, but please make sure you are getting a hold of this bulletin, that it is coming to your inbox and not going through to your spam. Oh, and there's my notes there. I'm always looking for ideas to make these meaningful for you. Next month, we're going to talk about it's a little bit focused on the level 3 and level 4 because we are going to talk about how to fill out your SACA. So if you are verifying this year or next, this is going to be a great webinar next month. We're going to kind of walk through exactly what we're looking for with the questions on the SACA or the self-assessment categorization application. If you don't know what SACA means, and how to tie your image trend trauma services summary report into your SACA numbers when we get to the registry section of your SACA. That's a very common thing that I see through verifications, and we'll just kind of walk through a SACA and so everyone is clear on what we're looking for with those questions. Now, for the more enlightening piece of the presentation today, Dr. Nicholas Voss, our epidemiologist, has had some 2023 data to report, and this is the part where we really want you to utilize the data, take it back to your administrators, make sure that your trauma committee are seeing these slides. Nick's going to tell you all about how to get a hold of different data points, different graphs, different charts, and here's Dr. Voss with the trauma system by the numbers. I'll shut up.
You have to shut up, Sarah. Great job. Thank you for the update. Oops, my camera's not on. Sorry about that, guys. This is a really interesting time in the development of injury epidemiology, especially for Iowa. We have been focusing a ton of energy in improving the analytics that we provide to the state, to our stakeholders, to the state leadership, our public health leadership anyway. And so I'm really excited to bring this report to you all. I'm excited for you all to read it and give me feedback. I did a lot of work to improve the analyses in order to provide a really good picture of what we really need to be looking at, instead of really just looking at what we've mostly done from what I can tell in past reports and past analyses I've reviewed. We've mostly looked at things at the record level, and now I'm taking this down to the patient and the injury event level so that we can start getting statistics about, for example, how often are injury events happening, where are they happening the most, and also thinking about the total number of visits or cases overall in the trauma system in any given facility. One of the things that I did want to share, we'll look at the PowerPoint in just a second. An exciting development that Sarah was sort of mentioning has to do with some of the bespoke or custom analytics that I'm creating for BEMTS. And one of these has to do with creating a public-facing repository where we begin to share our analyses. So we have a GitHub, we have a GitHub site, which is a repository of code where very soon, most of the code is totally private, but many of these repositories will be public facing, and in particular, the Trauma R repository is going to be public facing, where any researcher, any hospital, anybody that wants to utilize our programming language to interact with their data, especially their trauma data, I will have analytics published that you can share in. The Trauma R repository is currently live, and we do have a site available for the Trauma R package. And this is not, I have not published this quite yet, but it is in development status, and I have published how to calculate z-scores in R using this package with examples. And then we're also providing a way that you can utilize newer functionality, which is the relative mortality metric that I'm developing with Dr. Nick Napoli from University of Florida. And so these algorithms are things that he designed in late 2010s, like 2017, 2018, 19. And I'm putting these into R code, and I'm putting them open source with his permission. And actually, he's urging us to do this. He's very excited that we're publishing his methods. And so folks will be able to actually get into these types of analyses and do them for free at your own site. And so that's an exciting development. Trauma R should be fully published and ready for anybody to use anywhere in the world for free in the next couple of weeks. And then there's another package that we're working on. I'm not going to show that, because it's very much in an earlier stage of development. It's a much more complicated package, but it will automate the calculation of the NEMSQA, or the National EMS Quality Measures. And that's something that I'm also very excited about. You can expect a report coming out on Iowa's performance against the National EMS Quality Alliance measures in 2025. It's just dependent upon finishing this package so that we can use it to do all the analyses and the reporting. All right, so that's the nerdy stuff. I need to see the presentation. I think, Sarah, could you share your screen one more time, or share those slides, and I can work through those? I think when I shared my screen, it popped those slides off. There we go.
Yeah, let me know when you can see it. You got it?
Yes, yeah, and I'll flip through. I can
Oh, you got
actually
it?
control
Okay.
them. Yeah, I can control them since I'm a presenter.
Okay, perfect.
Let's take a few minutes, guys, to get back through. Maybe don't look at the slides because it's going to be like moving too fast. Okay, so here we go, about our reporting for the state of Iowa.
Okay, Nick, hold on, because I'm
Oh,
seeing, yeah. Are you sure
oh
you can
yeah.
control them?
Okay, I just synced. I synced us. Yeah, there you go. You're
Okay.
controlling it now. I was it wasn't synced. I'm sorry. That was my fault. Um,
Okay, but you can
Actually,
do it now?
you might want to go ahead and go through. You'll have to push the slides, because if you don't do it, I don't think everybody else will see what I'm doing.
Gotcha.
Sorry about that. I didn't realize. Um,
Well, I certainly didn't, so there we go. And just tell
awesome.
me when you want to advance.
Yeah, I will. Thank you. Okay, so one of the things that we've done, and some of you guys may have seen this at the CQuick meeting, so sorry, or sorry, the TSAC meeting. Sorry, you get a double dose. Everybody else, if you weren't at TSAC meeting, this will be new stuff, unless you already read the report, which would be awesome. But one of the things that I wanted to do was to begin to estimate the impact of injury events and visits to hospitals on our state, and on our population, on Iowans. And so the way that you can do that is by calculating rates of something. And then rates are typically discussed in terms of how many times something happens per so many people in a population. And then to take that a step further, that in itself right there is usually the crude rate. So you usually take the count, or incidence of something that's happening to the population. You divide that count by each group, let's say by county or region. You divide that by that region's population, or that location's population, and then what you typically will get, after you multiply that by 1,000, 10,000, 100,000, is the crude rate per 10, 100,000, 1,000, whatever you use as a multiplier. Taking that a step further is what's called age-adjusted calculation, where you take standard U.S. populations for each of the locations that you want to calculate this for. So this is always, I usually count this by county. And what you do is you use those standard populations that the U.S. Census Bureau publishes, and you use those statistics, or those numbers, to produce an age-adjusted rate, which basically what it does is it weights the calculation so that what you can do is use an age-adjusted rate to compare a rate across different geographical locations. And so that's the difference. A crude rate is just, you basically take your count, divided by your population, multiply that by 10,000, 100,000 to get a crude rate of how many injury events per 100,000 people. Our age-adjusted rate is also includes a calculation with the age-based populations for each county, and then you use those statistics to create your age-adjusted rate. So you can see the rates are similar. They move similarly, which you can tell, that's kind of a sanity check. You can tell that calculations are good, but you can notice that the age-adjusted rate is quite a bit lower, and that's because it adjusts for age groups. And so you won't have your crude rate will be affected by your largest population. So for example, um, our older age groups will drive the crude rate here, because there's so many more adults than children. But our age adjusted rate will demonstrate how much is injury impacting Iowans virtually at all levels of age, and so it is a much more useful and balanced metric. And so the age-adjusted rate, what we can do is we can read that that number 622.7, as you can tell from the captions in the plot, is that we have an age-adjusted rate of 622.7 injury events per 100,000 Iowans in 2023. So you could take that number and use the actual total population of Iowans to get the bulk number of estimated injury events. And so the problem is nationally, we don't have a good idea of what these rates look like in other states. Iowa has a very advanced data system for our injury statistics compared to most other states, not all. And so it's doubtful that other states are actually doing this. And it's also problematic because we can't really compare our injury rate to other states yet. But I'm hopeful that as we begin to publish these statistics, we begin to have these conversations, other states feel the pressure to look at the same numbers and to begin to do those calculations. So we can compare, like, how does Iowa stack up against other states? And so that's exciting. But what we do know is that in Iowa, the rate of serious injury events, so these are injury events that are serious enough to where somebody is taken by ambulance or by somebody to a trauma center to get specialty care, that number is 622 injury events per 100,000 Iowans in Iowa in 2023. If you look at other injury statistics published by the state, by our Center for Acute Disease Epidemiology, there's another researcher that does some estimation of injury, Dr. Tobiak. He works with the inpatient outpatient database, and you might notice that his rate calculations, including his age-adjusted rates, are much, much higher than my rate. I would say that this rate is probably more telling of what our state is actually going through, simply because it's coming from the trauma registry. The inpatient outpatient database looks at data from all of the hospitals, all the outpatient clinics, and will include like outpatient visits as well. So if somebody got a bump or a scrape or a bruise, then they got seen in an office by a physician or medical professional, that'll get counted in those statistics. Whereas we're looking here at the serious injuries, right? The stuff that we would probably be more interested in to know rather than contusions. We'd like to really see things that are really impacting people's lives and possibly even changing their lives for the worse. So this is serious injury rates for events. Next slide, please. The next slide is looking at admissions, or well, I typically say admissions. Sarah and Jill told me that probably wouldn't be a good idea. It could be misinterpreted. Could you go to the next slide, Sarah? Thank you. Okay, so in this slide, we're looking at visits to trauma centers. So this would be like at the record level. So like how many records were in the registry in 2023, 28,098. And so that is the number of unique visits. So if one person got hurt and then they went to Henry County Health Center and then they were transferred to University of Iowa, which is a very likely scenario, by the way, we would get 2 records in the registry for that person. And so this is looking at how many visits to trauma centers can we estimate per population in the state of Iowa. And so the age-adjusted rate for that is 767 visits to trauma centers per 100,000 people. And so you can see the number is higher for the visits because, again, we have transfers, we have cases where one person may have multiple different visits for one injury event. So that's why it's important to look at estimating the rate of injury events and also looking at the estimating the amount of visits. So the visits here show the impact on the hospitals, and the injury events show the impact on the community or the people. And so this will be most helpful when we have other states producing these types of numbers, because then we can compare, especially we can compare the age-adjusted rate, because all states, if they calculate that age-adjusted rate, have to use the same standard populations to get their calculation. And so then we're always comparing apples to apples, and that will be very helpful. And with this age-adjusted rate, when calculated for counties, you can compare counties with counties as well. And you could see sort of like where are the hot spots for serious injury events in the United States. We can't do that yet, but we're getting there. Next slide, please. Okay, so we had 118 hospitals reporting 28,000 incidents or records. 16,000, almost 17,000 of those were falls. Almost 6,000 of those were motor vehicle transport. And then we had almost 11,500 trauma team activations in 2023. And so you can see that level ones are significantly lower than the level two activations. There's many more of those. And we are seeing the number of trauma team activations going up year over year in the state of Iowa. We had roughly 456,000 EMS incidents, and almost 69,000 of those were trauma related. Next slide, please. Okay, you can see this here shows you the count and the proportion of records in the registry by trauma facility verification level. We can see that level threes have 35% of the registry, and then level fours have roughly 1/3 of the registry, and then the other third of the registry is in the level ones and twos combined. With level twos being underutilized, I think they're dramatically underutilized in the state. I think it would be worth looking at how could we make more use of those level two facilities. That may also reflect just the volume they can take, because there's just a few of them, similar to the level ones. Okay, next slide, please. Now we're going to look at the count of receiving facility cases. This is a number of cases, not incident or not injury events. And so we can see that the lion's share of these transfers are going to the level one and two facilities. Next slide, please. Now we're looking at the count of cases by ISS range, and then that's further grouped by verification level. And we can see that at the lower acuity patients are more frequently seen at level threes and fours, and then in third place would be the level one facilities. But when you come to the higher acuity patients, you see level ones utilized more. Next slide, please. And then when you look only at cases where there was a transfer, obviously the level ones and twos are the most common facility to be utilized, especially at the higher acuity. Next slide, please. So cause of injury frequency. So the way that you can read this chart, the way I designed it, was to be a little more easily legible. So if you look at the legend, which is kind of at the middle right, you can see that it goes from top to bottom, the different colors. So the order of that legend is the same order that you see in each bar from the right to left. So falls is first, as you can see at the top of the legend, then same level fall, then firearm, then motor vehicle transport, then other, then poisoning, then struck by or against. If it looks like one of the bars is missing, it's probably because there's a very, very, very low count, or there were none. And so for poisoning, you just have so few. It's just the bar almost doesn't show up ever. It's just such a small number. Struck by or against is a very small number as well, typically. And so looking at falls, you can tell that they take up the greatest proportion of the registry. And we also have firearms, motor vehicle transport taking up a large part of the registry. At every verification level, you see the very same trends. And so those are the three highest volume of injury types that we have in the state. Next slide, please. Okay, and then comparing leading cause of injury year over year, looking at from 21 to 23, we can tell that falls and motor vehicle crashes are leading the statistics in this area, with motor vehicle crashes relatively flat, and then falls taking up a greater and greater proportion of the registry year over year. And I think we are seeing a slight decline in the firearms. If I can look at those, I think firearms are going down. It's a very small proportion of the injuries that we see coming into trauma centers, but those are decreasing over time. Struck by or against is relatively flat, so people are still assaulting each other. Next slide, please. Motor vehicle crashes, I did this for Jill because she complained about it in the last report. Just kidding, she didn't really complain, she just asked me for it. She was very nice. The motor vehicle crash injury events have been steadily increasing, but they seem to be increasing at a very similar rate that we see with the overall number of injury events. So the spark line that you see on the right of this table is the trend from 2018 to 2023. So you're seeing the actual trend in that statistic, and we can tell that the proportion of injuries has been mostly going down since 2018 when it comes to motor vehicle crashes. However, it's slightly up in 2023 by about 10%, a 10% increase from the previous year. So there typically is some form of a positive rate of change, but the total proportion of injuries that motor vehicle crashes take in any given year has overall mostly been down, with the highest year being, I think, in 2020, in the last 6 years, and then it's just been going down for the most part. I think that this is a good sign. We don't want to see more motor vehicle crashes massively going up. And again, this is not DOT data. These are not DOT data. These are data from our registry. So we're only seeing the injuries that actually get reported, or when people actually come into a trauma center. So we're not seeing those fatalities where somebody was dead at the scene. So there are many of those, and those aren't reflected in these statistics. Next slide, please. All right, so this is one of the slides about average ED stay. One of the things I'm going to do with the CQuick indicators as I develop them for the reporting in for the 2025 reports that will come out in 2026, I'm going to be looking at the time from patient arrival to decision, and by popular demand. What we see here overall is that patients that have a trauma team activation in 2023 spend 36 fewer minutes in the ED. And so you can see that reflected in the activated group. These statistics are grouped by whether or not the trauma team is activated, and then by ISS range. And we can see that a full 189.3 minutes is the average length of stay for somebody with an ISS from 1 to 8, down to 165.7 minutes for somebody with this ISS range of 16 plus. And so we can see that those numbers increase dramatically with the not activated group, and I think that is very significant. And if we were to look at chi-squared tests of those statistics, we would see that they are very likely statistically significant, because each of those bins has hundreds, if not thousands, of records in each of them. Next slide, please. So then we also think about re-injury, and Dr. Jim Torner from University of Iowa and I worked on these reporting elements for a couple of years together, and what we saw, or excuse me, a couple of reports for a year. I was working with him for about a year, and you see here that so what this means is the dots, each dot is a patient, and so you see that the number of dots in the one around the one category at the bottom, which is basically the number of injury events that any one patient had. So each of those patients in that one group only had one injury event in 2023. And then the slightly bluer, lighter bluer color just above 2 is the number 2. Those are patients that had 2 injury events in 2023. And then the next group is 3 injuries, 4 injuries, 5 injuries. And then there's a very small group of people that had as many as 6 injury events in 2023, which means they had 6 unique hospital visit sort of cycles. They may have been transferred throughout, but they had those 6 visits. So this is an estimate. There may be some people missed in here, maybe some included that were not valid, but it's a pretty good algorithm. And what we have here is a visualization of the number of patients, the overall impact on our communities related to injury. And we can see here that there is a sizable number of people that have more than one injury event in any given year. And this is every year I found that there's a large number of these patients that are at high risk for injury. And so this slide just really depicts the that shows it visually of how concentrated our patients are in these groups and how many people in bulk, which are thousands, by the way, of people that are affected by this. Um, and so in 2023, I think the number was 969 people had one or two or more injury events in the year. Next slide, please. I think we're going to see that table next. Nope. These are the uh, cause of injury classifications for people that had one or more injuries, or two or more injuries in Iowa in 2023. We could see that falls are driving that. Yeah. So what does that mean? Well, it's probably related to elderly falls, probably related to a lot of nursing home falls. But this is still, I think this is still a topic worthy of investigation. And you do have, look at that motor vehicle transport occupant. We had 71 different cases, and so um, this is this is or sorry 71 injury events that involved re-injured patients. So this is a very important look to see that, you know, violence, motor vehicle transport, those are and you know there's motor vehicle non-traffic there too, um, and a motorcyclist. So if I group those up into, you know, just those motor vehicle ones, like motor vehicle pedestrian, put those all together, we would see that motor vehicle related problems are in the hundreds. Um, and so we need to pay attention to that. This is a population worthy of our consideration for prevention efforts. Next slide, please. So here I'm going to visualize the actual spread and prevalence of this in Iowa. We had the number of patients are increasing year over year, right along with the number of records or number of visits to trauma centers. So that number is going up of people that are injured multiple times. So it's about 4% of the registry or so. In 2023, but these individuals have a large proportion of the incidents in any given year, and we can see that the average number of injury events is going up slightly. So that means that while that number might seem small, 2.14, so the majority of people that do have more than one injury event in the state only have two injury events if they have more than one injury event. But that number is going up incrementally there. Seems very small by point. It's only by 0.02 injury events per person, but that means that we're having more people that are having greater than two injury events, and that's steadily rising. So that number is incrementally rising, and it shows me that we really need to pay attention to these statistics. We need to pay attention to this trend, and the percent change. The proportion of re-injured patients in the registry is also incrementally going up. So we're just having more and more people having more and more injuries. It's not fast. It's not a fast increase, but it definitely is something that we need to keep in mind. Next slide, please. Okay, so this is just sort of visualizing what's called a logistic regression model, or the outputs of a logistic regression model, which are called odds ratios. And odds ratios are things that people talk about all the time. So you hear this in different kinds of marketing schemes and different types of marketing for like medicines and things like that, where people talk about, you know, this can increase the odds by, you know, increase the odds that you don't experience something that you really don't want to experience, or that you do experience something that you do want to experience by 7 or 8 times. So you're 7 times more likely to do this if you do this. That's an odds ratio. It's an output from a logistic regression model, typically used for pass-fail. In this case, I looked at re-injured or not as the response variable, and then I just predicted re-injury by patient age range, basically, and you can see that over time the odds that a person have a re-injury in their life continues to go up, and it has more of an exponential relationship with the trend from age 50 plus. So that there is kind of more of an exponential change in that trend up in that statistic once you hit age 50 and you get older. So each of those statistics, you would read this as somebody that's ages 50 to 59 is 3.28 times more likely to have 2 or more injury events in a year than ages 0 to 9. So all these age groups are referenced by the age 0 to 9 group. So ages 70 to 79 are 5.26 times more likely than that youngest age group to be re-injured. And you might say, well, duh, of course they're going to be more likely than those little kids. But that's how logistic regression works. It's just how these statistics always work. And you may just be seeing this in a different way or with more detail than you're used to. But that's how these statistics always work. Odds ratios are always compared to something. And so in this case, we just compare to the 0 to 9 group in this case, just to see how likely if there is a trend up by age group in these groups, and we do see that, and that is concerning. And this also gives us a beginning idea of a machine learning exercise to categorize people and create a risk profile for injury, or what I would like to call an injury profile, that we can begin to understand how much risk is a person in related to their injuries, and that could include, are they likely to be re-injured? And I think age is a good start, and we can add more variables to that. Next slide, please. All right, this is Jill's absolute favorite slide in the whole world. She's never seen any slide ever that she liked more than this one. And this is actually looking at. Actually, I gotta see if she. I wonder if she's like saying stuff to me in the chat. Nope, she's not. Good. Yep. See, told you. So looking at longitudinally from 2019 to present, or 2023. How are we doing with average ED length of stay prior to transfer? So these are transferred patients, and we can see that among this group, the average ED length of stay in minutes in 2019 for transfer patients was 144 minutes, whereas it's 178 minutes in 2023 for the activated, for where trauma teams were activated. Whereas in the non-activated group, it goes up to 234 minutes on average for these transfer patients. So call the trauma alert. Next slide, please. And then looking at deaths, the morbid stuff. When I'm not doing injury statistics, then I'm usually, health statistics has me studying infant mortality a lot, or like child mortality. I just did a report on the child deaths related to motor vehicle and off highway vehicle deaths, and it's just so sad, but there's not very many, so that's good news. Here we're looking at mostly adults, and so there are quite a few, but we see that falls related to the Iowa unintentional trauma deaths by cause. These are directly from our death certificate data. We have an analyst named Josh Jungling, works for Health Statistics. He's my colleague, and he produces the actual categories and numbers. So I just basically visualize what he's already done. And so these numbers will be the same numbers that you will see in any other report he's done before. If you go and look at like the health statistics publications related to vital records. And we can see that the number of deaths by fall are increasing over time. And then the legend is keyed by order of the line. So falls, poisoning, motor vehicle, you can see those go in order from top to bottom. The lines do the same thing. And suffocation, fire burns, then drowning. And so we do have a slight trend up, very slight trend up in motor vehicle deaths, not necessarily crashes per se, that are resulting in a trauma center visit. Poisoning deaths are mostly flat for the last 3 years, but they were increasing from 2018. And falls are just continuing to increase year over year related to these traumatic deaths. Next slide, please. And the last one. Thank you guys for all your support. Many of you guys contribute to my reporting. Many of you guys provide caveats, ideas, recommendations, and I definitely listen to those. Hopefully you guys can tell that I do, because you will have seen some of your suggestions and ideas reflected in things we've talked about either in meetings or you've seen it in this report. So couldn't do it without you. Couldn't do it without Sarah and Jill, for sure. And yeah, I'll be letting everybody know when some of the software packages come out for automating trauma related analytics and EMS analytics. I'm very excited about what's coming next, and we've just got more stuff to do. It's just a lot. It's just there's a lot to do in this field, and I think we have a great opportunity with such a great data system and group of dedicated professionals like you all that are working in the system. Um, we have a great opportunity to engage in amazing CQI efforts, PI efforts, and doing that through a data-driven process. Thank you so much again. That's all I got.
Thank you, Dr. Foss. And as a reminder, the slides that we just visualized are in our 2023 Trauma Registry report, which can be found on our website, or we can drop the link in the chat as well. So I know we're over just a little bit for the hour, but I would open it up to questions. Again, these are our slides for your using, and we want to let you be able to visualize and use all your hard work that you're putting into the patient registries. This is where it comes from. Questions, comments? Okay. This is recorded, I think. And we'll have that posted to our website too. If you had to leave early, or obviously if you left early, you don't know I'm saying that, but we'll have this posted to our website. And I will let you enjoy the balmy 20-degree or 30-degree day we're going to have. So I appreciate everyone on the call. Thank you for joining us today, and stay safe out there.